So one of the things that happens with me is when in my office I have patients, like I told you before, they want to come to the office, we have them fill out paperwork, case review, and then we'll go through all their papers, do a phone call, do a case review, and talk about what's realistic, what's not realistic. One of the questions I always get asked with patients is, what's your success rate with autoimmunity? I say every case is different. I said it could be 0% or it could be dramatic, and I can't tell you what the variables are. I have no idea. I said you can absolutely fly out to the office, spend thousands of dollars on lab tests, do dietary interventions, take tons of nutraceuticals, and you may not feel any better. Welcome. And you know what happens? It's like all this weight just goes, whew, and then I do my best. And I really, really try every single case to figure out what I can do with them and make a difference for them or not. And but I can only go as far. It's kind of like a dance too with autoimmunity. They have to give and you have to give. Like you have to work on some mechanism. They have to go and try that intervention, and then you got to communicate again, see how that's working, and then you're going to the next one, and it's going to the next one. So some people you lose in the dance. Sometimes you lose them because they're tired of working with you and don't like you. Sometimes they're totally better and don't need you anymore. And sometimes they lose focus and then they call you back and you dance again with them and and you work through it, right? That's real practice, and that's okay. That's just the way it is. So I'm going to show you with some cases. Usually when I've been sharing cases with you, I'm sharing your real cases that you guys can follow along and see how they're doing. And for this one, I'm going to show you some cases that are more optimistic, because autoimmunity is so like, oh, I can't do anything, that I want to show you some good ones. Okay? That I definitely have cases, just like everyone has, where we try everything and nothing changes. Does that make sense? It really is rare where nothing changes. I mean, a lot of time, if all you can do is find their diagnosis, teach them the concept of what's happening to them, understand that lifestyle and sugars have a factor in their health, it is life-changing for them. Then if you go a little bit further and find foods that they interact with and get rid of those, and you go a little bit deeper and deeper, it can be profound. I mean, literally profound. And it is it's very nice to have that experience, right? Now, for me, myself, I honestly will go to New Patient Day almost every single time going, what am I doing? I'm not trying to lie to you. I'm being totally honest. I go, I have no reason in the world to treat this patient. But I also then think, well, what are they going to do? Where are they going to go? Because they've kind of exhausted options, then you kind of get back through it. And then I usually do a workup and go, oh, I'm glad they came in. But it's almost always like, I don't know if I should do anything with this. Do you know what I mean? Because they're so intimidating when you have someone who's in a serious autoimmune disease. Not like someone who's got a subtle Hashimoto, it's no big deal. When someone has severe neurological disease and they're progressing, it's very hard to work with. Anyways, so let me show you some cases. So these are more optimistic. I'm not here to blow smoke off you and say all my cases are like this, because they're not, okay? But I do want to show you some good ones. Now, ultimately, when you look at autoimmunity, remember, these are our key clinical competencies, and this is what we want to go through in a case evaluation. Identify the undiagnosed autoimmunity, whether it's the first time for initial diagnosis or you're finding other autoimmune reactions with one who's already diseased. Find the stages of other autoimmunities, stage 1, stage 2, stage 3. Identify lifestyle triggers, identify dietary protein triggers, identify chemical triggers, identify antigen triggers, identify breakdown of the immune barriers, identify mechanisms to improve tolerance, and identify strategies to recover from autoimmune flare-ups. So let me go through a case with you, starting with the medical history. So this was a patient that came to see me from Europe. She was a 34-year-old healthcare provider with a history of elevated ANA antibodies. So what do you immediately know? She's got systemic autoimmune disease. Chief complaint is extreme fatigue with significant drops in energy throughout the day, declining cognitive function. The patient has been on a gluten-free diet that has only had minor impacts on improving her symptoms. Only gluten-free, nothing else. She's still eating dairy and grains. Okay? So I had her fill out a metabolic assessment form. We didn't cover this in this course, we covered in the GI course, but I highlighted the sections they are. So category 2 are symptoms associated with intestinal permeability. Okay, so she has lots of GI intestinal permeability symptoms. This category 7 are symptoms associated with impaired biotransformation, and she's got some serious hypoglycemia symptoms. Okay, and then some insulin surgery. So she's got a roller coaster ride happening with her system there. Then I go on to the next page. She's got symptoms of electrolyte imbalances, sodium, potassium, electrolytes, and so forth. She's got tons of hypothyroid symptoms, mixed hypo and hyper, which is what you see with Hashimoto's. And she's got lots of female hormone imbalance symptoms over here. Okay? So listen, without doing anything further, you can already see dietary, lifestyle, sugar factors happening right there, right? So just the person, hey, I'm tired, and guess what? I have had some A and A antibodies. You immediately know they have systemic autoimmunity. Now you can see intestinal permeability, impaired biotransformation, hypoglycemia. So right, like 2 seconds, you can immediately find a lot of triggers. So when you see a case like this, you go, wow, there could be a lot of things that can make an impact on her, right? Because I know if I can improve her immune tolerance, that can make a huge impact. Her permeability is part of that. Her biotransformation is there. Her blood sugar spikes, they're there. She has both hypoglycemia and insulin-resistant blood sugar spikes. If I get that under control, that could be a factor. What's going on with her electrolyte imbalances? I need to find out if there's any kind of sodium-potassium regulation issue that's there. And maybe she doesn't just have lupus. Maybe she has Hashimoto's too, because she has both hyper and hypothyroid symptoms. Make sense? Okay. So we go through a physical exam. And this is what I found in the physical exam. Her blood pressure was 96/68. Not good. So you know what I'm adding to this list of possible diff dyes? Adrenal autoimmunity. There's a history of hypoglycemia and blood pressure this low and electrolyte imbalances. I want to ask myself, does she have any subtle 21-hydroxylase autoantibodies? Ultimately, I'm going to run Cyrix Ray 5 on her because I want to know where the rest of the autoimmunity is. But right now, I'm suspicious of not only thyroid, because she has mixed hypothyroid symptoms, but I'm also suspicious of adrenal because of electrolyte imbalances and low blood pressure and severe hypoglycemia symptoms. Okay? Signs of poor circulation that include pallor nails and cold distal extremities, white fingernails, cold hands. Thyroid palpation demonstrated a multinodular thyroid. Thyroid was enlarged. Even now screaming more Hashimoto's. Okay. So then we look at some labs. So I start with the routine blood work, and I look at her glucose, and it's 76. And that's within the reference range, but anything below 85, you start to see blood sugar symptoms with. And then I go through the rest of the blood chemistry report. Nothing really abnormal with her kidney, liver function, her electrolytes, her iron levels. And then I take a close look at her ferritin. Why do I want to take a look at her ferritin? It's an acute phase reactant. I want to see if it's up, because that'll go up with inflammatory responses. And if it's up, what do I want to do? I want to make sure she's not taking any iron. High ferritin plus iron and autoimmunity is a bad combination. Okay? So I see that. Then I look at her thyroid. Well, she's not hypothyroid, but look at her T3 levels. It's low, so she's not converting T4 to T3. So she has what's called a thyroid underconversion pattern. And inflammation can dampen 5-deiodinase activity and impact T4 to T3. Plus, we found 2 foods that cross-react with 5-deiodinase, one of them being latex haven. So now that we've done our cross-reactive research, I go, hey, she's underconverting. Does she have antibodies to latex haven and avocado? Because they impact T4 to T3 conversion. Right? So I'm just going through my initial thoughts as I'm working the evaluation. I look at her vitamin D, it's 37.3. I mean, that's in the normal reference range, but I like to see that around the 50 range. I think most people that work with patients like to see that a little higher. Vitamin D is essential for immune modulation and regulatory T cell function, so the vitamin D level is a little bit low. I look at her white blood cells, and I see they're 5.6, so that's good. They're not, doesn't look like she's fighting an active infection, and they don't seem depressed, so that's a good sign. So then I look at her lymphocytes, the differential. First of all, she's not anemic. I look to see if her lymphocytes are abnormal, and they're within the normal reference range, but look, the lymphs are in the higher end of normal. You see, 14 to 46, she's at 43. So I'm a little suspicious here. Look at her monocytes, eosinophils, basophils, neutrophils, the Pac-Man cells, the innate immune system. See if there's any active triggers there, and it all seems okay. But I don't like this lymphocyte response. So we look at the T and B cells. Because remember, the lymphocytes are what? They're T and B cells. We look at the T and B cells, and I'm looking at them, and you can see the C819, look at her B cell count. B cell count's fine. I look at her CD3, her cytotoxic T cell count, that's fine. It's within right in the middle. I look at CD4 with CD helper cells, those are nice. I look at her CD8 suppressor cells, and I see they're 0.5 elevated, which is no big deal. And suppressor cells, if they're up in autoimmunity, that's great. But they're within the high end of normal, so I'm not considering that. For the most part, there's nothing terribly abnormal with her white blood cell count. So at this patient right now, I'm not thinking, I'm going to jump into antigens. Do you understand? I'm not thinking I need to jump to antigens because they're not seeing any complete immune dysfunctional profile. So she has AA antibodies that are there. She's really tired and fatigued. Her white blood cell count's still okay, so that tells me her immune system is fit and healthy, and she doesn't have any major shifts in her T and B cell profile. All I'm seeing is suppressor cells 0.5 outside the lab reference range. Everything else is close to midline. So when I go through the different list of things to do for autoimmunity, I'm now taking antigens as far as like viral infections and pathogens and bacterial infections and kind of putting on a lower priority list. Make sense? I'm not excluding it, but there's a place, the first thing you have to do with autoimmunity is go, where am I going to start? Okay, now I don't like the fact she's just gluten-free because gluten may be not enough, especially with someone who's got systemic autoimmunity. So as I'm looking at her history, I know I got to dig more with dietary proteins, right? But so far, my initial evaluation of her her general routine lab work is giving me some direction of where to go. You guys with me so far? Okay. All right. So then, she's got some sleep rhythm issues, and look at her cortisol profile. The black line is the patient. It should be right in the middle of these two red lines. Her cortisol in the morning should be high up here, and then at night it should go down. So she's almost got a switched rhythm. So this is a disrupted circadian rhythm. That's not good. Disrupted circadian rhythms are going to be a factor in immune regulation. Okay? Now I'm not going to jump into adrenal support here because you can't do anything with adrenals until you get blood sugar stability. Do you know what I mean? Like, her protocol is definitely not going to be, here's your adrenal adaptogens, here's your adrenal cofactors, here's all your adrenal support. That would be a complete waste of time. I can tell you from experience because I've done that for many years. I have many clinical battle wounds from inefficiency all over. And so I would definitely want to support this, but it's going to be at a blood sugar stability level first. You know, you can't jump to adrenals without blood sugar stability. Okay. Now I'm going to look at this. Okay, now here's your array 5. We already know she has DNA antibodies, so she has antibodies to DNA. Now look what's showing up here. Thyroglobulin. Collagen complex. And myelin basic protein. Okay, so now, my next clinical question is, what stage are these in? Okay? What stage is her thyroid in? Well, let's look. She's not hypothyroid yet, but she does have thyroid symptoms. So it's not silent, and it's not disease, so it's stage 2. She's an autoimmune reactivity. Okay? And then if we go back to her array 5, she has no joint complaints, no swelling, nothing. So her collagen complex antibodies are what stage? Silent. I did a thorough neurological exam. I do that with every patient. My neurological exam alone takes me almost 2 hours. Everything was normal. So this is, for me, silent. But I'm going to have to explain to her, like, hey, this is where the autoimmunity can go. Now, you guys see that the myelin basic protein is in the red, and these other ones are in the yellow? That doesn't tell you what stage they're in, so remember that. The antibody level doesn't tell you what stage they're in, because antibodies only do what? They only attach to the protein, and then the T cell response against those things could be a bigger factor, right? So she could have myelin basic protein, but her brain inflammation, her microglial cells, her astroglial cells, her barrier is all intact, and right now, there's nothing happening there. Okay? But I always now know, as a clinician, I'm going to be looking for neurological exam findings. Her blood-brain barrier integrity is going to always be important to me. Head trauma is a big deal now, because her head trauma can now turn on autoimmunity. Lots of good studies on that. If you guys remember in the neuroinflammation course, we showed you some papers where lots of people have circulating neurological antibodies. They're ubiquitous, and it's only when their barrier system breaks that they become a problem. So right now, her blood-brain integrity is a key factor for me as a clinician, as I'm trying to help her manage her case, and I want to explain those concepts to her. Make sense? You see how much information you can get just with some routine tests if you know what to look for, and you like questions to ask, and you understand autoimmunity. And then this is like patients, when you go through this stuff with patients, they're like, oh, thank you. Right? You do it. You do it every day. Okay, now, I look at I already know she's on a gluten-free diet, so why am I running this test? This is gluten antibodies. I'm running this test because I want to look at transglutaminase. Her transglutaminase 3 is up, which means she has autoimmunity against her skin if she has a gluten exposure. Okay? So I want to let her know, listen, you're on a gluten-free diet, but if you get exposed to gluten, you may have some skin reactions. Or if you're having skin reactions, you may have some undiagnosable or unidentified gluten exposures. It's possible with this immune response. Okay? And then I go through and I look at array 4. She's on a gluten-free diet, but look at her cross-reactive foods. Well, she's testing against all the milk proteins and against grains, a couple grains. So it's for sure, you cannot eat gluten and you cannot eat dairy. Now here's the interesting thing. Gluten and casein cross-react with myelin. Imagine her blood-brain barrier breaking, she has myelin, and then these milk proteins now cross-react. Bad combination. Make sense? So if her blood-brain barrier is compromised and these milk proteins get through and they can cross-react with the myelin autoimmune reactivity, it can be a potential problem. So a better way is to say, stop eating casein. Stop eating milk protein. That includes goat's milk, sheep's milk, all animal milks have casein. And then really the ultimate thing would be to at least for her, we're there with the gluten dairy free. So then I look at her barrier function because I know she's got barrier problems. And what do you guys see here? She's got intestinal permeability, but guess what? LPS is high. She's got endotoxemia. I don't like that. Because that means these LPS can activate her autoimmunity. It's not just some subtle leaky gut. LPS directly turns on toll-like receptors, which turns on NF-kappa beta. If I'm dealing with a systemic autoimmune disease, and all of a sudden their leaky gut totally matters to me much more than before. If I didn't see the LPS elevated, I wouldn't care as much. But I don't like that LPS elevation there. Okay? Here is her chemical immune reactivity. What do you guys think? Do you see total immune chemical tolerance loss or just a few things? It's kind of in between, right? It's not like just a couple and it's kind of more than you like, but it's not all of them. So we're seeing aflatoxins, formaldehyde, isocyanates, benzene, and heavy metals. The only thing she mentioned was she doesn't like being around cigarette smoke. It upsets her. And she's got some benzene ring antibodies. Cigarette smoke produces benzenes, okay? But these other things were hard to identify. Now she's showing mixed heavy metals. Do you guys want to do a challenge test? No. Now, I'll tell you the worst combination. Myelin basic protein, positive like it is, blood-brain barrier permeability, milk proteins are already off the chart, and now you do challenge. That's how you trigger autoimmunity. The cookbook recipe right there, autoimmune trigger. So we don't want to do a challenge test right now. Maybe in the future, but not right now. Okay, I mean, these are subtle cases. Okay, so now I have this information about her autoimmune pattern. Does that make sense? Like, the fact she's walked into my office with extreme fatigue and ANA antibodies, I know a lot more now about her. Again, and she's confused about what to do. She's a healthcare provider, conventional healthcare provider. She doesn't know what to do. She just knows she has any antibodies, and basically her doctor's saying, you have them, so what? So I start with level 1. Everything we just went over, I would explain to her. And I would have her understand, hey, can't eat milk, you have myelin, and you have milk. They can cross-react. That's a dangerous combination. I know you're gluten-free. It is not enough. You're cross-reacting. Not only is it just gluten-free, you have transglutaminase factors. You have an autoimmune response against gluten. It's against your skin, but that's bad enough. So you can never eat gluten, and you can never have cross-reactive foods with gluten, which are grains and milk. Your grains aren't showing up, all of them, but they're going to show up. So just stop eating grains. Make sense? Okay. So we go through. She's under a lot of stress also. So we look at her lifestyle. We want to look at her exercise levels, her dietary management. We definitely want her off dairy. And, well, let me just kind of, so you go through each of these steps and you kind of figure out which of these things apply. So let me go back for a second here. So she is raising her kid. She's under a lot of stress at work. So stress is a factor. We didn't go over that in history yet, but I just want you to know that. So we have to talk about how she can handle stress. Maybe she can have one day off a week. Maybe she can do some stress relieving issues, but it's a factor. When you're seeing myelin basic protein antibodies and ANA, like, you can't play around with that. That's some pretty serious stuff. Then we look over lifestyle management. She's not exercising at all. She's sedentary. We want her to do something. And something that she can do that doesn't cause her to not be able to recover the next day. So light enough, aggressive enough to help support her immune system as much as possible, but not to the point where she can't recover. And then what about dietary management? Well, for sure she's got to get off dairy. I'm looking at her salt, and she's got some significant blood sugars. She got electrolyte imbalances, so I'm not sure what's going on with salt. But would you restrict her salt intake? No, because her blood pressure is so low, she's probably not even retaining sodium. So even though we show you research studies on, like, salt can be a trigger, you're going to see in my protocol with her, I put her on salt. I put her on sea salt throughout the day. And it didn't flare her up, it actually helped her feel better. So be aware of that. Now, I know she's got some serious blood sugar spikes. What about antigens? Did you guys do anything here? I decided not to. Chemicals? Well, she's got some chemical immune reactivity. I have to kind of consider that. Immune barrier, she's got some permeability issues, and then I got to work on her tolerance issue at this point. So this is what I did with her. I put her on the first thing I said is, the number one thing we're going to do with your case is stabilize your blood sugar. I don't like this abnormal cortisol rhythm. I don't like her hypoglycemia symptoms. I don't like her blood pressure being that low. So I told her, you're not allowed to have energy after you eat. That means your blood sugar is too low. So you have to eat frequently enough so you don't have those big improvements in your function afterwards. And then you got to make sure you eat and you don't pass out afterwards by your content of foods. So after a few weeks, she was able to figure out eating frequently enough with certain foods that didn't cause her to feel totally energized after you eat, because she was eating frequently enough to avoid her blood sugar spikes. And she immediately, when she avoided dairy and grains, her blood sugar stability, insulin surges weren't happening. Okay? So she's on a gluten, dairy, grain-free diet. I gave her sea salt, despite the research. We increased diversity of fibers in her food rotation. Why? Improve her immune tolerance. Added mild to moderate exercise to her daily routine. 1 day a week dedicated to her. Take some time off. I put her on licorice root. Licorice root helps her the compound in licorice root impacts an enzyme called 21-hydroxylase, which helps with sodium retention and cortisol, slows down cortisol breakdown. I put her on glutamine, leaky gut support. I gave her short-chain fatty acids, and I gave her vitamin D. And that's it. And I needed to go very slow with her because some people have a personality where she was coming from a conventional healthcare model. She didn't want to take a lot of supplements. She needed to really be handheld to control her blood sugar levels and get them stable. She came in, we did about 2 Skype follow-ups over a 1-year period. Because I'm teaching her the principles, and we check up in a couple months and go, did you get your blood sugar stable? These are what I need you to make sure you know how to do. Don't get tired after you eat, and don't feel energized. And over a period of time, she figured that out. I corresponded with some emails between those 2 months with some questions she had, and she figured that out. So I do a follow-up with her, give her another few months to do a follow-up with her. She comes back a year later. We do some lab tests. So this is now her Cyrix Array 5. Don't be impressed. And this is before and after. So she's in remission. Do you guys understand that? Okay. I don't have any antibodies on this PowerPoint. They're in remission too. She is not cured. Do you guys understand that? She's in remission. She can get a cold tomorrow and flare up. She can get a head injury tomorrow and develop MS. Because she has mildly basic protein antibodies. And she had them in the past. They're just in remission. But I found the susceptibility when she was vulnerable, so now I have a baseline to work with, okay? Here's her leaky gut. It's better. It's gone. She doesn't have endotoxemia anymore. This time I checked her blood-brain barrier because I was really worried. It was intact. Here's her leaky gut before and after. Here's her chemical panel before and after. Now, would you go after chemicals? We know what I decided to do? I go, you can take a detox drink every day, just like I use the product called Clearvite. Just drink that once a day and just let it be. And it was like, hands off. Call me if anything happens. You're good. You have significant vulnerabilities to blood sugar spikes. You have significant vulnerabilities to stress. You got to find a stress reduction pathway. And those key lifestyle factors and a few things put her in remission. Make sense? Because there's no way in the world I'm going to go into a GI panel now and find a pathogen and try to treat it and do all this other stuff and now put her through chelation and all that stuff. Holy moly. That's what I used to do in the past, and that's when I used to mess up patients all the time. Okay? There's a point, once people get into remission, you need to stop. You guys understand? It's like it's a balancing act. Okay, let me show you another case. Okay, here's a next case history. Patient, progressively over several years become unable to walk, must walk with a walker. So I'll tell you the story behind this. This patient went to school with my wife. She calls her up and says, hey, I can't walk anymore. She goes, what happened? She goes, no one knows. I've gone to every specialist. I've spent 2 weeks at USC neurology department. They tested everything. They told me there's no reason why I can't walk. She goes, I know your husband does some things with like brain, nutrition. Can I see him? I'm like, I can't see anyone. I'm already booked. But when your wife tells you to do something, you do it. So these are her symptoms that she put on her case review. I'm completely off balance. I stand up and close my eyes. I circle. I drag my feet because if I raise my foot to walk, I lose my balance. If I lose my balance, I cannot recover and fall. This is her typos, not mine. I will walk at home. In public now I use a walker because my doctor was afraid if I continued to use a cane, I would throw my alignment off even worse. Even now and then I get these bad headaches. It's pressure, the base of my head on the right side. Tylenol, Advil, aspirin doesn't help. Only heat or muscle relaxers work. When I sit at a corner or a high borstal with my feet dangling, my feet tingle and can sometimes swell. Then it's hard to get up and walk. I just need to get going. I can't jump. I can't move my feet fast. I get cramps in my shins at night and sometimes cramps in my forearms during the day. Spinal tap. I went to USC. MS specialist because the chiropractor went to alleviate my back and told me to get possibly checked out. The results were no MS and no other neurological disease. The blood work came back as low B levels. That's a big clue. I have since started taking liquid vitamin B and getting shots once a month. Pills do not absorb for no reason. My levels are now in higher normal range. All tests have shown nothing. Nerve conduction test results, 5% muscle loss in leg, left leg, EKG results, nothing. The 5% muscle loss in her leg was something that threw me off because she actually had a radiculopathy disc herniation years before. It was unrelated to her inability to walk. It was just on top of it. So she's basically going through history. And here's her physical exam. Do you guys see what I'm trying to see if she can balance. She can't hold on, and she tells me when she lets go of the walker, she starts getting vertigo and dizziness. It doesn't matter if they're open or closed. Either way, both ways. When she closes it, it's much worse. I'm trying to see if she can do a Romberg, and she can't stand. Okay. She has what's called idiopathic sporadic ataxia, because when you listen to her history, which we weren't able to play, the key things that came out was sometimes it's worse, sometimes it's better. Idiopathic sporadic ataxia means there is no cause for ataxia. There's no head trauma, there's no stroke, there's no TIA, there isn't MS, there isn't anything there that can cause ataxia. And sporadic means it comes and goes. So I'm suspecting she may have gluten ataxia because she eats the standard American diet. The most common cause of idiopathic sporadic ataxia is gluten sensitivity. Okay? And by the way, with gluten ataxia, this was a study that was published with 68 patients that looked at all the different findings of ataxia, published it in Brain. They found only 13% of them have gastrointestinal symptoms. These are people that have gluten ataxia do not have GI problems. They just have gluten, destroy their brain. It's transglutaminase 6 reaction. It's this. You guys remember this slide I showed you? Remember this? Gluten cross-reacting with cerebellum. You remember this? Inflammatory responses against gluten specific to gluten ataxia. So the only thing I did with her, listen, let me tell you what happened with her. She was really, really scared. Okay? And she's like, I don't know what to do. I'm all, listen, I just want you to do something for just the next couple of months. I just need you to go 100% off gluten. Actually go off gluten, go on a gluten dairy-free diet, just right away. I want to see what happens when you do that, because you have, in her neurological exam, she had no muscle weakness, no upper motor neuron signs, no signs of brainstem issues. Her brain was intact except her cerebellum. It was very specific to the cerebellum. History of idiopathic sporadic ataxia, no cord issues, no radiculopathy, no neuropathy, no myelopathy, no muscle weakness, no fasciculations. It's like it can only be one area. It's the cerebellum. And the cerebellum disease, idiopathic sporadic, and the number one cause of that is gluten. Okay? So we put her on a gluten-free diet. Here she is 6 weeks later. No more vertigo, no more dizziness. Big difference. 6 weeks. Just removal of the dietary antigen that cross-reacted. Powerful stuff. Now, what do I want to do next? I want to go in and see if she has barrier issues and gut issues and other cross-reactive things. She won't let me. She won't let me go any further. She's so happy of the recovery, she doesn't want to chance anything. And she's also really scared. It's the first time in many years she's been getting her function back. She doesn't want to play with it. I have her orders for Cyrex all set up for her. It's in the computer base. We have the requisition forms. She literally has to just walk to the lab and hand it over and get her blood draw. She won't do it. It's okay. She still continues to recover and get better every day because now she's getting to use her brain and do her things. But I wanted to show you this case because when you have specific molecular mimicry and you avoid that triggering compound, it's profound for some people. Does that make sense? Now, I can't wait till she's ready to go to the next step because I have a lot, now you can go into all the other things, but I don't know where to go because I need to get the rest of her patterns. Now, what do I really want to see with her? I want to see, does her blood-brain barrier intact now or not? Is it cerebellum or other target proteins? Does she have completely lost her chemical immune tolerance or not? And if so, do I need to work on her chemical tolerance? Does she have lost her food protein tolerance? Do I need to work on that? Does that make sense? Maybe, now we need to really focus in on diversifying her gut, supporting her tolerance, giving her short-chain fatty acids. There's so much to do, and it's just kind of waiting for her. So this is also another real part of autoimmunity management. You can't always do what you want to do. You have to work with your patient's level and their fear and their time to go in and do the test. Make sense? So hopefully we'll go deeper with her. But right now, I just wanted to show this case with you because it's specifically related to cross-reactivity. Interesting? Okay. Now, case number 3. 19-year-old male with family history of autoimmune disease and reoccurrence of Epstein-Barr virus that would incapacitate him. So for the past 3 years, he gets yearly reactivation of Epstein-Barr responses. The last time he got it, he was hospitalized. And when he was hospitalized, his ANA titers were off the chart. Do you guys understand what's happening? He's getting Epstein-Barr, churning on systemic autoimmunity. So we went through the medical history. These are the key things from the medical history. Removed 4 wisdom teeth under anesthesia, but not put to sleep. Pain was so great I was taking Vicodin for 16 weeks. This is in 2015. Very high fever, severe throat pain, needed to treat with antibiotics, likely the first activation of Epstein-Barr. So he had this dental procedure done that seemed to be something that weakened his immune system right after that, and that's when he had his first Epstein-Barr event, 2015. 2016, underwent a week of flu-like symptoms in May, what I believe to be the second time of Epstein-Barr activation. 17 years old, very high fever, extreme throat pain, weakness, and general pain. 2017, red butterfly rash on face, malar rash, that they diagnosed themselves. So, if you get a chance, you can go through the history, and it just talks about, I'm not going to go through all of it for you, but it talks about what they've experienced, what they went through with, and I say they, I mean the family, the mom, very dynamic, really very smart, took care of her son, was really looking at all the different approaches for functional medicine. And here's the lab test in the emergency room from the last immune response. So look at his white blood cell count. How does that look to you? It's 16.1. Do you guys think there's an infection? Yeah. Neutrophils are low, lymphocytes are high. So, what kind of infection do you think it could be? Do you think it's more bacterial or viral? Viral. Eosinophils are low. And remember, these are percentages of white blood cells, so if one goes really high, you just stop making the other ones. There's no point for his immune system to make eosinophils now. It just needs to make as much lymphocytes as he can to deal with it. He has to get his adaptive immune response up. His absolute lymphocyte count is off the chart. Here is Epstein-Barr virus. Titers come back positive. He's got active Epstein-Barr in an acute phase. ANA titers, off the chart. You see that? This is the classical example of what I was showing you guys yesterday with the research on Epstein-Barr, specifically triggering ANA antibodies because of this EBANA2 expression with Epstein-Barr on causing DNA autoimmune reactivity. And this is what's known in the autoimmune world as a seasonal pattern. So look at this paper, seasonality in autoimmune disease, the contribution of the 4 seasons to the mosaic of autoimmunity. Seasonal patterns of infectious disease are correlated with the onset of exacerbation of autoimmune diseases. During the winter, increased incidence of Epstein-Barr virus infections are associated with MS and SLE flares up respectively. This is so common, it's in the literature. Okay, so, and they go on to show like when flare-ups happen, and for different people, they have different theories of what these things are. And then after this patient had a flare-up with Epstein-Barr, ended up in the hospital because of the severity of his flare-up and his systemic autoimmunity, he came out from the hospital, was able to be released, and his mom got together with some healthcare professionals and started to run some Cyrex testing. These aren't ones these were not under my care. The mom was very proactive and went and got some testing done with some practitioners. And what do you guys see here? Intestinal permeability, leaky gut, and endotoxemia. Do you guys see gluten sensitivity? Yeah, gluten here. Do you guys see autoimmunity against gluten? Right here, TG2. Is this temporary or permanent gluten sensitivity? It's permanent, it's TG2. Okay? So you guys remember, autoimmunity is multiple layers of stuff. So he's got a susceptibility to Epstein-Barr. His immune system is now seasonally flared up. He's had an Epstein-Barr infection 3 years in a row. This last one put him in the hospital because of the ANA autoimmunity turning on. And here's the array 5. Where's the rest of the autoimmunity? Thyroglobulin is showing up. So he's got some thyroid, adrenal, and neurological. So now your next clinical step are these stage 1, stage 2, or stage 3? Are they silent? Is it autoimmune reactivity or is it autoimmune disease? You can't tell from the antibody count. You'd have to look at the clinical symptoms and exam findings. So when he came in to see me, it was months after these test results were done by another practitioner. I did a head-to-toe exam, really thorough. Everything was normal. Nothing. I could not find anything wrong. Super healthy. And which is kind of weird when you work with a chronic patient all the time. You see someone with a normal exam, you're like, this is so weird. Your blood pressure's perfect. Your nails look good. You look healthy. Your balance is perfect. And you go through all the tests and go, okay, that was interesting. Totally normal. So everything's silent. So he has a susceptibility for flares up seasonally, and it can turn it on. Now sometimes when people get these flare-ups, it does not turn off. He's healthy enough where it turns on, and then turns off. Make sense? Okay. Now, this is his chemical reactivity panel. What do you think of that? Not so good. So lots of chemical reactivity. This is complete loss. This is loss of chemical tolerance. And then these are food sensitivity profiles, and you can see it's got multiple reactions to foods. The physical exam was normal. Okay. So this is my actual report. And when I was doing this case, I had no idea I was going to use this for a seminar. So if you see any typos, I apologize, but there could be some in there. So I put the patient has susceptibility to recurring Epstein-Barr virus with reactivation of his virus the past 4 years, between the months of April through May. During the examination today, there was evidence of he had enlarged tonsils. However, there was no finding associated with significant immune deficiency. He also suffers from underlying autoimmunity that include laboratory history positive ANA antibodies in 2018. In addition to transglutaminase 2 antibodies, 21-hydroxy antibodies, TPO antibodies, alpha-beta tubulin antibodies. It is clear after detailed history and examination that the autoimmunity target proteins have not expressed to autoimmune disease and are currently in silent stages. There's a potential of acute Epstein-Barr viral reoccurrence to trigger autoimmunity. And these reports that I write are only, honestly, for me. Because when I do my follow-ups, I want to remember the whole case. And with autoimmunity, you have to give it some time between your trying something and doing the follow-ups. You want to have good notes, so you remember the big picture. Okay. Patient has not been following a gluten-free or dairy-free diet while away at college. That's not good, because why? He's got transglutaminase too. And remember, it's like variables that all add up for some autoimmune disease patients that flare him up. Maybe if he actually goes gluten-free, then that next year he may not get that Epstein-Barr. You know what I mean? He also noted that he has felt better with an autoimmune paleo diet in the past. He went on it. He felt better, but he's not following it. He's 19. He also exhibits long periods of time between meals and symptoms of hypoglycemia. That's not good. That's a trigger. He also has periodic episodes of depression, poor memory, and impaired concentration. He is physically active and participates in weight training 3 to 5 times a week. Really good shape. The immunological response to transglutaminase 2 raises significant risk for autoimmunity if the patient is unable to or unwilling to implement a gluten-free and dairy-free diet. There are also concerns for antigen-triggered autoimmunity and potential for development of hypothyroidism, Addison's disease, and neurological autoimmunity or lupus in the future. At this point, a detailed evaluation to confirm lupus autoimmune markers and a detailed evaluation of the immune system with a comprehensive T cell and B cell profile will be conducted. The initial goal of treatment is to strengthen the patient's immune system in order to avoid a reoccurrence of Epstein-Barr reactivation. There's also some concerns to improve peripheral circulation support his cognitive function at this time. So he has some subtle circulation issues. Okay. So my thought here is here's what they're saying. May is coming up. This is when he has been getting his reinfections, and his last one turned on autoimmune disease. So what would you want to do at this point? What do you think? Like, for sure we want to deal with the gluten issue, make sure his blood sugar is stable. If you had a response with autoimmune paleo diet, please go back, especially months before your seasonal trigger, because he's got the seasonal trigger autoimmune pattern happening, okay? So goals of clinical management. The initial goals of treatment are to improve and evaluate the patient's immune function and the prevention of another Epstein-Barr viral reactivation. Do you guys understand why? Because of the potential to specifically turn on ANA antibodies. A comprehensive T cell and B cell profile are conducted at baseline, and the test will be repeated within 8 weeks to determine if the nutritional protocol is having positive impacts on his overall immune function. At that time, there can be an emphasis to improve his immunological tolerance and reevaluate his immunological tolerance with repeat testing to both chemical antibodies and dietary protein antibodies with Cyrix rate 10 and 11. Confirmation of ANA antibodies and other markers associated with lupus is necessary. Strategies to improve brain function with gluten-free and dairy-free diet in combination with nutritional strategies to support vascular dynamics with nitric balance and exercise support brain function will be examined. So my goal is I got to strengthen his immune. I got to see what's going on with his T and B cell profile, and I got to get his immune system stronger before the next event in May. Okay? So now they're in my world. The other lab tests were what they came in with. So now I get in and I get to evaluate his labs. So here's his blood test. How's his glucose look? It's okay. It's within range, 92. Anything you guys see with BUN, creatinine, magnesium, electrolytes? The chemistry panel looks pretty good. No problems there. Go on to the next page. Transaminases look good. Look at ferritin, it's an acute phase reactant. That looks fine. Look at the lipid panel, looks fine. CRP, got to make sure that's okay. It's 0.18. Now, what does this now serve for me? It's my baseline. I'm always going to look at 0.18. If this goes up to 2 or 1.5 or anything else, I know they're getting some inflammatory responses. Thyroid, normal, because remember he had thyroid antibodies before. I want to make sure his silent, since that test hasn't gone into what? autoimmune disease. That's the advantage of having an array 5, because now I can know what things to really look for. Is he progressing or not progressing? Is he in remission or is he progressing? Right now I'm feeling pretty good. He's in remission because I'm not seeing any acute phase reactants up. I'm not seeing his TSH up. What if I did this panel? His C-reactive protein was like 7. His TSH was now high. What would that tell me? He's not in remission. He hasn't recovered from that first attack. He's progressing. You guys understand? But I'm knowing what to look for because I have that past information about his autoimmunity. So then we look here. His vitamin D levels are 47.4. That's not too bad. White blood cells, they used to be 16. They're 7.3. But that makes me nervous because when I start getting above 6, look at lymphocytes. They're calmed down. They're 20. That makes me feel a lot better. I go ahead and check the lupus profile, anti-DNA, ANA antibody, these anti-antibodies, ANA, DNA, Smith, they're all negative. So he's in remission. You understand? He's not cured. He's basically a flare-up away for flaring up his systemic autoimmune disease, and the key thing is we don't know if this time around he'll stay there. Okay? So then I got my baseline immune profile. Look at his natural killer cells. And I got to tell you, at this point, I know he's got a viral response. The most important cell for me are natural killer cells. Because I know for viruses, that's the key cell that makes the difference. So his natural killer cell is normal, but it's 141. I don't care. That's my baseline. Make sense? And then I have his CD, well, let's see what do we have here. Percent natural killer cells, 9.4. And then I have his cytotoxic T cells, so right around mid-range. And those are the key things I'm looking for. So here's my clinical pan. Initially, a Th1 and Th2 challenge with X-Viramin XFLM will be recommended. So let me explain what I mean. X-Viramin is a product that has all the Th1 NK cell stimulators. It has like maitake mushroom, astragalus, echinacea, okay? And XFLM is a product that has pine bark extract, acai, and resveratrol, B-cell support products. He is instructed to consume 2 capsules of X-Viramin 3 times a day with meals and determine if he notices any symptoms of flare-ups of an autoimmune disease. If any adverse symptoms are reduced, he's instructed to immediately stop the protocol and to contact our office. If there are no reactions induced by X-Viramin, he's recommended to have a washout period with no X-Viramin for 3 days. It was then recommended to try XFLM at 2 capsules 3 times a day with meals for 3 days. If any adverse symptoms are induced, he's instructed to immediately stop the protocol and contact our office. If he does not have any adverse reactions to X-Viramin or XFLM, he's recommended to take 2 capsules of each product 3 times a day with meals. So you guys understand what I'm doing? I'm still terrified in any autoimmune disease patient to start using immune enhancers. But I have to get his immune system up so he doesn't get another Epstein-Barr, and I want to get his NK cells up. So I'm just having him slowly try one thing and make sure he doesn't have a flare-up. You guys see the thought process? Okay. So I put him on high amounts of A and D also. I put him on a general adaptogen and some immune support and some C. And then we do a follow-up with labs 5 months later. AG ratio is 0.2 up, nothing is significant there. All of the lab chemistry panels are normal. CRP is a little bit higher than before, 0.38. It's not too much of a difference, but it's still there. His thyroid is still not showing any abnormal patterns. We got his vitamin D up, maybe a little too much. Once it breaks 100, I like to kind of back off, so the D worked. His white blood cells, look at this. What do they now show? 3.8. Is that good or bad? To me, this is good, because I didn't like 6. 6 is about to have an attack. His lymphocyte count was 20, now it's 40. That's good, in some ways. And I look at his natural killer cells, and they are now improved. So here's the difference. In 4 months, I got his NK cells to go up to 218, and his percentage of NK cells to go up to 14.5 from 9.4 as white blood cells are no longer in acute response. I'm seeing these results and I'm pretty happy. So now we're crossing fingers to make sure he doesn't have a flare-up. Because we got his immune system strengthened, right? And patient had not had an Epstein-Barr flare-up this year, breaking the pattern of 3 years in a row without any flare-ups. That's how we managed his autoimmunity. This is a preventative case of autoimmunity. Make sense? So now at this point, he's really on board. He's really following a gluten dairy-free diet. He's taking his supplements regularly. He feels dramatically a lot better. Now the next layer of stuff he's got some histamine reactions, and he found some quercetin really helps him with that. And we're kind of working through some other stuff. But at this point, we know how critical it is for him to support his immune system, and what kind of factor his transglutaminase and gluten sensitivity have is a different story. But on future care, we definitely want to look at his risk for thyroid, all the RAE5 stuff we want to keep an eye on. But the problem was that ANA autoimmunity is so serious that I really stopped focusing on everything. I went right to antigen model, right? And the antigen model was to really get that Th1, Th2 system kicked in. So this is a case. Let me show you a third case. MS. This is the patient that came in. This patient came to my house in my front door with his new wife with a stack of labs going, I need help. I'm going, what are you doing in my house? Anyways, here's a young kid. He was scared. He had 3 consecutive MRIs with more demyelination. So, MRI 521, new lesions in the corpus callosum, white matter lesions comparable with MS. He had enough significant plaquing where he had MS, and it was getting worse and worse. So, we basically, there's a follow-up test, again, 2016. He keeps progressing. New plaques keep developing. So he comes over with a stack. So we immediately go into a neuroinflammatory autoimmune protocol, start supporting his tolerance. So basically, I put him on all the anti-inflammatory stuff we talk about in the neuroinflammation course. I'm trying to get his blood-brain barrier to heal. Okay, I mean, this is like right now. I'm not waiting for tests to come back in 6 weeks or 3 weeks. We just start supporting him. We start improving his immune tolerance. So Reparavite is for leaky gut, and Enterovite are short-chain fatty acids. Clearovite is for detox, phase 1, phase 2. Biotransformation, that's what I use. Nitric balance is there to improve vascularization and blood flow. Liquid D was a vitamin D source, high-dose vitamin D. And then the next MRI is scheduled. And for the first time, immediately after that, his MS stops. Simple. The right protocol, the right time to block neuroinflammation, heal the blood-brain barrier, support, repair. Make sense? And then his exam findings change. He still has some remnant upper motor neuron signs. But this is a work in progress. But this is an example of what you can do. So this person's in stage 3, autoimmunity with plaquing and demyelination. And sometimes a protocol like that can be profound. So anyways, that's case 4. Anyways, so those are some cases I want you to see. I don't have all great cases like this in my real practice. I have enough to keep me going. And I wanted you to see cross-reactivity. I wanted you to see how remission looks like. I wanted you to see how an infection pattern looks like. And I wanted you to see sometimes how simple it is to look at an MS pattern. Let's take a break, and then we'll review and do questions.